the reason why I really wanted to bring this to CoMMP is I and my team have been asked to create something that cuts across lots of different avenues. This idea of a data registry, we in mobile medicine, fire, EMS, community paramedicine, all of the shades of that, ground and air and so on. There's lots of talk from now and again about registries, which are essentially databases with personal health information. So we make sure we have a level set on the language. And basically the idea of, when we talk about registries, historically, it's been things like trauma and the CARES registry, places where cardiac arrest information, again, trauma, moving parts. Now we're seeing that definition evolve a bit. COVID has become a big one with the immunization registries. And then this idea was brought up, and it was from an academic medical center. I won't mention who they are at the moment, but an academic medical center folks who understood and had pioneered the end of life registry. So essentially the idea that if a crew is going to roll up on a patient who is having a cardiac arrest, a respiratory arrest, if that patient was in a hospital setting or if that patient is in the market, in grocery store, the question of, does the mobile medical provider or does the office-based provider know what this person ultimately wanted, have access to a database that has their personal information and have their wishes represented. And so kind of an offshoot of that, of the success that project has had there, was born this idea of a comparable registry for pediatric patients. So essentially focused on, funny that Amy, who runs, basically the executive director, Amy, I don't know if you can hear me yet, but I was literally just kind of giving a little bit of an overview of what PULST is and the concept of PULST and the PULST registries. So your timing, your ears were apparently burning. So thank you for being here.
Oh, thanks.
Basically this idea of if a patient who is a child is going to be engaged by mobile medicine in the field, on the field, perhaps, on a ball field, right? Or in a home, wherever they are, does the crew that arrives on the scene have the ability to know what's going on with that child? And that was kind of a thunderclap that went through my mind. It was one of those things that I've certainly had this experience before in our industry, but it was kind of that, how did nobody bring this up before, again, concept. And the difference, of course, between other aspects of what we do and the idea that information may need to be shared with various stakeholders is that we're talking about children, right? And so if you're dealing with kids, then you're dealing with patients who can't necessarily speak for themselves. You're dealing with kids whose parents may pick them up and move them from Washington State to Texas. You're dealing with kids who can't necessarily describe their symptoms, or whose symptoms may not be known because they've never experienced this problem before, or they've never been to a doctor yet to diagnose whatever is going on. And so the sheer number of unknowns made it really interesting to me as a technical project. And then for CoMMP, this idea that no one aspect of our industry owns this conversation, right? Whether you are basic life support, whether you're an on-site school nurse, whether you are air medical critical care paramedic, it really doesn't matter, right? You will engage from time to time with patients who can't speak for themselves. And you may, and in some cases, by the way, represented by some folks on this call, you may actually have adults who are incapable of describing their condition, perhaps because of underlying cognitive deficiency, or something that's gone on since they were a child and continues to this day. Think of things like ranging from epilepsy to hemophilia to other conditions, and so they may not understand or have had the opportunity to talk to you about it. So everybody in this industry will face this type of situation, and therefore I thought it made it perfect for CoMMP. So let me give a quick overview of CoMMP for those of you who've not come to one of our meetings before, and then just kind of, I'm going to go through a couple slides, really just one or two slides here to sort of lay the land and then open up to the discussion. So for overview, for those of you who have not already been here, first of all, I'm Jonathan Fite. My day job, I run Beyond Lucid Technologies, and I have been enthralled by the concept of the Congress of Mobile Medical Professionals, what became the Congress of Mobile Medical Professionals, which was started by a fellow named Anthony Correa. I don't think he's on the call yet, but Tony should be joining us. In really the early days of the pandemic, last March or April, Tony, who has a very long experience in both fire and EMS in a variety of leadership roles, basically came up with an initiative that was intended, good morning, Clay, thanks for being here, was intended to slam together different parties from across our industry with the idea that if COVID-19, which had challenged fundamental aspects of how our industry works and how our industry gets paid and how our industry shares information and what it's exposed to on a regular basis, not an irregular basis, Tony basically said, we need to put people in a room together and see what happens. You know, when I was in college and studying sociology, the idea of society emerging sui generis, emerging kind of on its own without an underlying foundation was a really a core aspect of sociology and psychology, and that's really what Tony's vision was. This idea that if you put people in a room together who are passionate about what they're doing, they will come up with solutions to problems that you didn't even realize that were there, or they didn't realize one another could address. And to be honest, the first conversation that we had, I didn't know if it was going to be interesting, but Tony's a friend, and I was more than happy to have, to support his initiative to bring people together. And I got to tell you, in 12 years in this industry, that was one of the most fascinating conversations I've ever had. To have people, all of whom want to move the ball in the right direction, move the industry, progress the industry, do it respectfully, do it without regard for rank, patch color, without regard for whether you're full-time or part-time or private or government, it didn't matter. The idea was you were committed to a cause that was making your communities healthy, and that was something that I certainly could get behind. And a lot of other people did too, because we ended up going from 10 people that first week to 40 people 2 weeks later. And now we've got over 700 or so people on social media channels, Facebook and LinkedIn and a website. We host conversations on somewhat regular basis. They've been a little less regular now because of COVID and some of the organizational challenges that places are having. But the idea was to really provide an opportunity for us to take what, again, Eric Cheney and Clayman both are here, will probably remember from last January's HIE meeting that took place in Washington, D.C. The phrase was brought up, islands of success, quote unquote. And to me, that was kind of the emblemification. It was the concretization of a really, really bad problem that our industry has, right? Because we don't need islands of success. We need an archipelago. We need bridges between those islands, because if you are providing care in Chester County, South Carolina, or you are providing care in the Albany region, there are, of course, going to be differences. There are things like weather, there are things like legal differences. But at the end of the day, there are so many more commonalities that we should not be solving problems in bubbles and then waiting until we bump into an article in GEMS or EMS World or modernhealthcare.com to be able to say, hey, I could have used that 3 years ago. And so the mission of CoMMP was to close that gap, to provide a space where people could share ideas, where there's no vendor specificity, there's no dues to pay. This was really an ecosystem where we could create occasions for encounters that might not otherwise happen, and they are happening. And it is extraordinary to watch this actually work. So this idea that there is a mode of care where on the one hand, everybody on this call will have experienced engaging with a patient who couldn't speak for themselves, whether they're adult or a child, but particularly kids who might not know, whose parents might not be there, whose parents might be scared out of their minds about what's happening with their child. And on the other hand, the idea that kids tend to be highly mobile, right? Unlike if you have a parent, and I was talking to a colleague about this just yesterday, realizing that if you have an elderly patient who is diagnosed with cancer, and that patient has an ecosystem of an endocrinologist and an oncologist and gerontologist and so on, they are not likely to leave that area while they're under care, right? It's just kind of the nature of the beast. You know, your ecosystem, your people, your friends, your family members, they're in your neighborhood and you kind of stay there. With kids, that's not the case. And so Ron Nichols, who I saw joined, I think, Ron, you're still here, right?
I'm here.
Right. So Ron and I have been engaged in incredible depth on this with respect to COVID-19. Also, folks like Joe Cassiotti in the Houston area, in this fact that in Texas, they're dealing with this with COVID, right? You have patients who are moving from Dallas to Houston in between the time that they got their first shot and their second shot. So if that happens to patients in the span of a 28-day period, we can imagine what would happen to a child, right, who may have been diagnosed with something when they were 3 years old, and by the time they're 10, they don't live there anymore. And so wouldn't it be amazing? And why aren't we enabling the data to move with them, right? That's the idea here. And you sort of take what pulsed is. You take these end-of-life orders and this sense of a patient's health story, and you jack it up onto another pedestal, because now you're talking about not just a single piece of critical information, but perhaps an entire body of critical information that everybody on this call will at some point in their career have said, you know, I really wish I knew that when I showed up. And so that was the idea for this conversation. So with that lengthy introduction, I've given you a little bit of comp. There is no hierarchy. Every opinion is requested, respected. I swear to God, if you guys are all really shy with me, I'll start calling on people. You know I will. So we will ask that before the end of the day, before you leave, because I realize people may have to come and go, or people may have to leave at the top of the hour. I did allocate 90 minutes. We usually go 60, but we have gone as long as 120. So I figured we put some bounds around that. Please do, if you have not already done so today or in general, put your contacts in the chat. We may have follow-up questions. People have made spontaneous conversations offline and solved local problems by making those connections. So please don't be shy. Talk to each other, ask questions. I'm not checking the chat as often as I otherwise would while I'm sort of going through this, but when we open it up for conversation, I most certainly will, and try to make sure we get the conversation going. I've given you the overview of the pediatric project, and I'm going to show you a little bit of what we have so far today. But this is really about learning. Right, the mission of this project is to put together, and again, I think what we're seeing today, and again, Clayman and Eric Cheney and a couple other folks from government, very, very happy to have you here, because as you can see, and this is what our mission has been, we are bringing together on this call physicians, nurses, medics, firefighters, government officials, data geeks, health information exchange, right? And represented in other folks who not necessarily be here, but are certainly paying attention, legal and billing and sort of the other aspects of what we do as a practice. We each need to hear from each other. So I saw Greg Babel, I believe you're here, right? Greg, I don't know if you're able to make it.
Yep, my hand is up.
There you go. So
I'm very respectful.
Perfect. Like I said, sorry, I've got some of the windows closed, or I'd be looking at way too much on one screen here. Oh, I see it now. It shows a little hand. So I think what we really want to do, Greg has been a formative catalyst of this type of conversation. He put the call for contributions, or as he likes to call, brain juicing, because I love that. He put that out to a listserv of the American Academy of Pediatrics, and based on the responses that I got from some folks with AAP, the timing could not have been better. I mean, there are people who have been talking about this type of bridging of the gap and of conveying information for a very long time. And so now to have you guys together on the phone, I think we have an opportunity for the docs and the medics and the firefighters and the government folks and nurses, et cetera, to talk to each other here. And that's really what we want to accomplish. So definitely don't be shy. And with that, I'm just going to show you a little bit here of kind of what the concept is. This unbelievable explosion of cuteness that just happened to show up on your screen is indeed my daughter. So I will be happy to take the credit for that. I should say I don't take the credit for the cuteness. I take the credit for the picture. The cuteness is my wife's doing. So here is really what we're trying to address. And so I'm gonna sort of throw this out there and then leave it to the mercy of the court, so to speak, to tell us how close we are, how far away we are. We are trying to ask the following question or questions. First and foremost, if you were going to, actually, let me say, before I jump into this, are there any questions, if anyone wants to come off mute, any questions or concerns about what I've already laid out with respect to CoMMP and the mission of the project. I'm going to give it about another 10 seconds. And okay, guys, I'll check the chat real quick. Let's make sure that there's nothing in there. Okay, hearing none, I'm going to carry on. But again, at any point, come off of mute, jump on in. This is definitely not intended to be a lecture. It is really intended to be a conversation, and I just want to lay some groundwork. But then I'm going to start to open it up. And Greg, since you're now showing on my screen, I'll probably call on you first. So we are intending to ask a couple key questions here, and we need desperately to have the two sides at least of the exchange of information to be talking with one another here. If you were going to roll up on a patient who is in distress, who is a child, who has a healthcare context that you need to know as field providers, again, and sometimes I may say EMS, you guys know that I mean mobile medicine in its broadest sense. Whatever your patch color, whatever your service level, if you were called out 911 and you were going to show up at the patient's side, what information would benefit you? And so in terms of your ability to engage that patient most efficiently, most accurately from the get-go, that would reduce the need to scramble for information, or worse, the requirement, shall we say, to operate in the absence of information. So that is what we are trying to address. These are a few categories that I came up with, as well as that were fed to me by folks in response to the calls that we put out over the last couple of weeks. Terry, I see your hand. I'll come to you. Thank you, sir. Just real quick. So the list that I came up with were physical disabilities, things like epilepsy, muscular dystrophy, which tragically has come home to our family over here in just this past week with a death in the family. So muscular dystrophy, whether on the lower acuity side, like a spinal muscular atrophy, or a Duchenne's, right, where you may be counting the minutes. Multiple sclerosis, ALS, Lou Gehrig's disease, other physical disability like blindness, deafness, in my case, Tourette syndrome, or other conditions that someone may not necessarily understand. Second category here, autism, or other sensory and cognitive disabilities that may make it difficult for the patient to convey what they're experiencing, or in a more acute sense, will the lights or the sirens cause other issues? Will they cause the patient to react in a suboptimal way, or in a way that may impact care, or may impact the ability to talk with them or their parents, etc. Immunological conditions, obviously brought to fore through COVID, probably more than anything, but certainly when you look at lots of rare diseases that can affect the immune system. Hematological issues, again, we think about car crash plus hemophilia, right? That can be a very important combination clinically, I would imagine, but I want to hear from you guys. I'm not a clinician. So how would a diagnosis or a bracelet that says hemophilia modify care? And if that bracelet isn't there, how would that affect things? But one of the conversations we've had with the program organizers that I'm working with on this is that this is not only limited to folks to children who have disability or severe illness, because we know that kids get hurt. So if it turned out that a kid had got a concussion on the field, or their eyes were disoriented, all the other things that we know, or if they had ingested something intentionally or unintentionally, would it be important and helpful to know that they had an encounter like that a week earlier? We start looking at things like football injuries and so on. Allergies, medical frailties, rare diseases I mentioned, cancer, and the topic of high-tech kids. I had never actually heard that phrase before, but that came from Bruce Baxter in Connecticut, who referred to children. He said he had encountered early on in his career a case where a child had a breathing tube, and the breathing tube was pinched. And so the kid was in school. The kid became hypoxic. Nobody knew how to deal with the equipment that they were dealing with. And we know that in Texas and in Oregon in the past 2 weeks alone, right, power outages have been a huge part of this conversation. If you guys are not already familiar with the Empower initiative through Health and Human Services at the federal level, right, these guys focus on providing guidance, at least conceptually, to EMS, mobile medicine, fire, et cetera, about patients of all ages who have medical equipment that is tied to electricity. right? So if the power goes out, what happens? And so again, to what degree would information about that be helpful to you? Second category of question, what data that would be helpful in the field tied to the practice in other settings of care? And so this is where I really want to open to you guys to tell me and to tell each other, if you are a receiving clinician at a hospital that is going to receive a patient, how much information augmented into the patient's hands in the field, or in the provider's hands in the field, would be helpful or hurtful or disruptive, et cetera, overkill on the receiving side. And that really leads to sort of this third question of, we talk often in this industry about access to information and speed of access, but how much is too much? And so really, would it help, would it hurt, and sort of what information, because the last bit here that again, we kind of want to go into is the types of information that we've been collecting, and I'll come back to this in a couple minutes, but I just want to flash it on screen here. These are the categories that have come to me to date by folks that in the last 2 weeks that we have been telling about this meeting, and they really range from the kind of obvious ones like demographics and medications to the type of gear that they have, what types of signal information we could have, like if the person's got a funky heartbeat and we have a history of EKGs for this child, biometrics, a photo of the kid, but also possibly a photo of something that makes them comfortable, like a photo of a teddy bear or a photo of a family member or their dog. Right, patient-specific protocols. So we've had some really interesting discussions about the types of data. What we haven't yet had is how much is too much. So if you were going to look at all of these data and then you were going to slim them down to something that could be reviewed in 90 seconds while en route, while you're riding shotgun and your your colleague is driving, what information do you need now? And speaking of attorneys, he just showed up. So Zeke Peters. Zeke, thanks for joining. I was just talking about lawyers, so thank you for being here, buddy. And health information exchange. So with that, Terry and Greg, I'm going to throw myself to your mercy. Either of you want to come off of mute and go first. But again, I think, what are we missing? What is if we were going to rank order these things in terms of absolutely need this information, nice to have this information, would rather not have it in the field, but want it eventually kind of information. That's really what the kind of granularity we're trying to get to as we look to the tech that we need to build around it. So Terry, you want to go first, followed by Greg?
Sure. So a couple of things that come to mind early on are, you're dealing with a range of providers, from fairly independent paramedics to a very rigid kind of mother may I kind of system like we have out here in Southern California. But to get to the heart of your question, what do you need to know and how soon do you need to know it? In other registries I've had experience with in the past, I was involved with one probably a decade ago for geriatric patients, where basically there was a unique identifier which could be translatable to a QR code or some other digitized code that would allow that registry to be rapidly searched. What I would hope would be in there essentially is obviously the demographics, their medical history, but to a point, because anybody who's muddled through the ICD codes know that that's way too much information. So in some cases that needs to be more tightly categorized into specific areas versus
like what? Yeah, can you dig into that a little bit? Because that's exactly what we want. Is if you were going to say which of the medical history aspects you actually want, and there are a couple in the chat that we'll go through in a minute. John, I may call on you, so you're on deck.
So,
but Terry,
for example,
can you
with diabetes, we care that they're diabetic. Do we care about every subdiagnosis of diabetes that they've ever had from their endocrinologist and every lab result? No. But if this information could be tied to, obviously by the patients or their parents' permission, to a health information exchange, where as that information is updated, that it was available to the field in real time. As far as patient-specific protocols, I think that's a difficult thing to achieve on a macro level, because, take something as like, a specific ventilator, for example. There may be specific protocols for that ventilator, but or their condition and settings and so forth. But even in many systems, even if those specific information is available, the ability to intervene is often not available to the pre-hospital personnel. And in some cases it may be. So perhaps, having that information more readily available where medical direction would be able to simultaneously access that information and be able to provide guidance to intervene would be beneficial as well.
So let me ask you a question. So it sounds like what you were saying there, for instance, is given the type of equipment, some things you'll be able to work with in the field, some things you might not, but you'd almost envision a parallel registry that ties into that, where things like equipment and the ability to reference instructions quickly, I would anticipate. Not a manual, but kind of a do this, do that.
Right. So for example, like in our system here, if we had a kid on a ventilator, the response would be take them off the ventilator, bag them into the hospital, just get here quickly. In other systems I've worked in, the answer would be, okay, here's what you've got, here's how to troubleshoot the machine. You get online, advice through medical control. And in other systems, they may be able to independently manipulate things based on those types of protocols. So I think that there's value in having that information available, but there needs to be a practicality to how it's presented so that it isn't distraction. It doesn't become a distraction in systems that wouldn't allow or currently wouldn't allow that type of intervention.
Okay.
But,
ask you.
Yeah.
Go ahead.
But being able to then have that information available for the hospital they're going to, especially if they're not going to the hospital where they routinely seek medical care, having their specialist contact information, having the nuances of their treatments available to that facility may make a huge difference in the speed in which intervention can be provided in some cases.
So let me ask you a follow-up question, and then I'm going to go look to Greg, and then John Lovett, and call to you. You're in Los Angeles. Well, you work in Los Angeles. You apparently live on some planet in another galaxy, at least based on what I can tell.
Far, far away.
Indeed. With a nice soundtrack. So I mentioned the Empower program. In Los Angeles, you're going to have, just by sheer volume, you're going to have more patients that are on medically electrified equipment. One thing that I've often wondered and discussed a bit with some of the folks at the Empower program, which is a function of ASPR at the federal level, is the education that needs to happen to the providers about how to use that directory.
So the providers probably don't even know what that directory is.
And so let's come back to that point. That's I want to get the question out. I do want you to answer that, because that's really my thought is, let's assume you showed up at a patient who is on a ventilator. A, do you know that ahead of time? B, if you were going to know that ahead of time, what do you need to know? For example, do you need to know the model? Do you have any training? Again, you've worked in rural systems and urban systems and all over the country. Do you get any kind of training, and I have a note here from someone about the type of information that might be available on a console, for example, in the midst of this encounter, but there are knobs on the front of that ventilator, right? There are buttons on the front of that ventilator. Do you have any practical experience training to use them? Okay, so tell me about that, because that's to me seems like a gap that, if we're going to talk about this type of conversation, probably needs to be closed as a corollary part of it, is to say, if this is what the kids in your community have, this is what you might need to engage. Have some idea of how to do it. Otherwise, you're kind of up a creek anyway, and like I said, you're going all emergent as opposed to being able to deal on site. Tell me more.
So hold on, Jonathan, I have to jump off for 20 minutes, and I'm going to be back because listening to you talk for 30 minutes now, mine's exploding. But I'm sorry, I got to jump off for another call right now. I'll be right back, guys.
Okay, thanks, Terry. Sorry, it's time. Go ahead, Terry.
So it depends. I mean, in our system here in Los Angeles, that's a non-starter. Plain and simple. Take them off the ventilator, bag them to the hospital. It's emergent care only. There are systems where providers are well trained in ventilator usage, maybe not that specific model, but they're in the principles of manipulating the ventilator, and those systems may allow them in an emergent situation to do so, but not here, for sure. So there's a lot of variability. You know, it's the conversation you and I have had many times is, if you've seen one EMS system, you've seen one EMS system. And so to look at a product that's going to provide some continuity of care as the patient moves throughout these different EMS systems with different scopes of practice and different levels of training, the information which may be useful is going to vary as well. So in that regard, the presentation needs to be non-distracting, but in a way that you can get to the information that you need if you have more flexibility in the care that you're able to provide.
Okay, so that's sort of a perfect segue. Love it. Can you come off of mute real quick?
Yes, sir.
Hi, glad you're here. And wow, we're going from whatever planet Terry's on to wherever you are, which is where I want to be. So I'm not going to tell too much of your story, let you tell whatever you want to share, but you did note something here that I think is a very important segue from what Terry said. You wrote in the chat here about a good bit of granularity, such as equipment, hospitalizations, and so on, but then you wrote chromosomal abnormalities. And so what I'm trying to figure out the balance on is, again, how granular is too granular. So in light of what Terry was just mentioning in terms of the training that people have to deal with what they encounter, if you tell me how you, as a clinician rolling up, if somebody told you that this patient has Fragile X syndrome, Triple X syndrome, you know, run the gamut, right? And those are just ones that come to my mind right now. But any of those types of anything that is granular at the cellular level, right? Or that this patient is a cancer patient. How much detail is too much detail? How much detail is enough detail? Do you need to know that they have cancer? Do you need to know what type of cancer? Do you need to know whether they're in remission or what meds they're on? So how deep would you want to go when you roll up and are dealing with either a child who's in pain or a child who's in crisis? And and I say the one being, you have to maybe deal with the patient first and then ask questions. The other might be, I need to ask some questions to get more context. So where does that line sit for you in terms of the practice in the field?
Well, I think the primary diagnosis is going to be important no matter what type of patient we're going out to. And obviously, because you know my background, I focused on the chromosomal abnormalities because it's probably one of the least dealt with things in EMS, children who suffer from chromosomal abnormalities. And in full disclosure to the group, I am the parent of a moderately to severely disabled child that has a very rare chromosomal disorder. And she's only one of 134 patients in the world with her disorder. So from my perspective, and having been on both sides of the fence of being not only a provider for disabled children, but being the parent who's had to call 911 for his disabled child, I look at it from the perspective when those EMTs or medics roll through the door, that a database that they could access the primary information. And then from my perspective, I agree with what the previous person said, since you started talking, my mind's going in like 50 different directions right now for the benefits of this. But to kind of streamline it, to me, it would be they need the primary information that's going to help them the best care for the child that they're facing, and ancillary equipment, ventilators, settings. And I agree with Terry, not every service in the country does pre-hospital ventilators. We happen to have quite a few in our system that we deal with, and we do utilize them when we can, with parental support or caregiver support as well. So from my perspective, rolling through the door, the primary information would be the key part, like life-afflicting disorders. And then I would envision this to have drop downs that would allow us to tap into things as we progress through the call. So if it's a respiratory driven call and they are home vented, obviously we want to know why they're all of a sudden a respiratory patient if they're home vented, what's going wrong, troubleshooting techniques. I mean, I could literally talk for an hour, so I don't. I think that gives you a basic approach.
Okay, I appreciate it. And I'm sure we'll want to dig into that. Bimal, you had mentioned that you thought John's approach was the right one, and you're on deck next anyway. So turning to you, then Ted, then John, and I don't see a last name for John, so I don't know who that John is. But if you want to put that in the chat, that'd be great. So Bimal, you're next, followed by Ted.
Yeah, so I'm not a pre-hospital medical provider.
That is fine.
Don't play one on TV even. I'm a physician and an informaticist here in Ohio. The point that I want to make is that I think that we're in danger of conflating two distinct functions of what Jonathan's describing. One is a data repository that is housed in an HIE essentially, and the other is the actual presentation of that data to various members of the chain of pre-hospital care, whether that's medical control or somebody genuinely out in the field, and everything in between. And so I think the question of how much is too much or what's the minimum amount of information, those are questions that are really about how do you interface with this data set. And the correct answer to that is essentially local, right? Like I actually think that the goal should be to enable local entities to craft that in ways that are suitable for their practice environment. On the other hand, you want your HIE, you want your actual data store to be able to service the widest range of use cases for pre-hospital providers that you can. So that's sort of one big concept I want to get out there. And I think John agrees with me more or less. And then the other thing that I want to say is, so I'm a geneticist by training. And so my patients have incredible medical complexity. The purpose is to help people do the right thing for the right patient in the right way at the right time. And so one of the challenges that I think folks need to think through is not just pulling in descriptive data for this is true about this patient, but to the extent that we can pulling in, these are, or at least making available, these are things that can and or should be done in pre-hospital settings. So for example, talking about patient-specific protocols, it's fine. Like if you have some vent protocols and stuff, you want to make them accessible, even though many pre-hospital providers may not use them because the answer is actually going to be, you know, pop them off their vent, put an ambu bag on, bag them back to base lights and sirens, and we'll figure it out when we get here. But there are actionable protocols in the field. So for example, state newborn screening programs identify, you know, hundreds, if not thousands of people a year in given states who have critical inborn errors of metabolism, whose resuscitation needs are unique. And knowing before as you're arriving on the scene that active resuscitation of this patient actually requires dextrose containing fluids, then that seems like that's the actionable thing. You don't actually need to know that the patient has cobalamin C type related methylmalonic and methylcitraturia or something, whatever the esoteric name for the genetic condition my patient has. What you need to know is that they need to actually be resuscitated and maintained on high dextrose fluids as soon as possible, you know. And so I think that having protocols available is important, and then thinking through how are ways that we can make actionability obvious to individual sites so that they can figure out what level of which of these protocols are actionable in a way that is relevant to their local practice so that they can draw those things to the front. There may be places where they actually want all of that event protocol stuff. There may be places where they say, look, our practice model is, you know, grab and bag, in which case knowing how to fiddle with the vent is wholly irrelevant. And so the HIE can have that information, but it shouldn't be the thing that we draw our pre-hospital providers' attention to.
So obviously there is an enormous amount that you just threw out there, and some of those very long organic chemistry names give me hives, so I'm going to skip over them. But the I should say the pharmacological names, I'll be proper there. But two questions really came to mind, because I think you mentioned them all right at the beginning of your discussion about health information. So you mentioned health information exchange, and there are some people actually on this call who work at health information exchanges in a couple different states. So I think this is a relevant to, I'll just call out Dawn and Zeke and certainly Clay at the national level. Two questions that come to mind. And I think one is more about the data, and the other is about the practical effect of the data, Bimal, to your point. So first and foremost, you talk about HIEs, you talk about local use. Can you talk to me about how your thoughts as an informaticist as well as a clinician, doesn't matter that you're not in the field, that's sort of the point here, right? Is we want to cross that line. You have to receive data too. So when local changes, right? If you move from Washington to Texas, if you move from Colorado to California, and the or even within a state, if you move from a rural environment in Western Colorado into Denver, right? And so the applicability of information, the access of information, which HIE's region you're operating in, may not be the same. So talk to me about how your definition of local use changes when you go from a place that does have patient-specific protocols or event-specific protocols to some place that doesn't, or vice versa. The child moves into an area where there's an expectation of a certain degree of knowledge. I dealt with one of these in California recently, where as a patient, just like John mentioned, the child has a very rare condition, and the only reason that the fire department in the county knew how to deal with it is because the parents went to the fire department when they moved into the region and said, our child has this condition, right? So that information is not available in HIE. California's HIEs are a disaster. So how does that affect when local changes and how the world what local means? And the second part, just as an attack onto that, is you mentioned about bag the patient and take them lights and sirens where they need to go. How would your answer change if you're dealing with a patient with a sensory disability, for example, or an autism, where, for example, writing code 3 may actually make it worse, create them some kind of other pain, but that's part of your protocol. And I think that's an important part of this conversation when you're dealing with a patient who might not be able to say, turn it off, right? Or it hurts my ears or whatever. Instead, they're going to react however they're going to react. And how does that bump into operational protocol? So two small, big questions. But again, given your purview on informatics, I think you're kind of the perfect person to deal with this. And Ted, you're on deck.
So I'm going to cop out a little bit on the first question in deference to people who actually work on HIEs. But I guess the point that I would make is, again, assuming that you are within, if you move between completely different data contexts, if you move from California to New York, then what's relevant is whether or not there is a single shared data context. And if the goal of this project is to actually provide a national registry of this data, then that I think is actually a really laudable goal, to make that data available in local context, however people want to pipe into it. If you want to take the aspect of, if you move within the same data context, but to different practice parameters, so data that was not relevant where the child was suddenly becomes relevant where they are now, and vice versa. This again points to the virtue of making the underlying data as expansive and supportive of various use cases as you can, recognizing the practical limit that if the place where you came from just doesn't generate the data that is relevant and make it available, then it's just not going to be available. And I don't know that it's on you within the context of this project to solve that problem.
So to be clear, real quick, just to be clear, so the goal here is to initially start with a state initiative that's essentially pioneering this. There's a state that we're not talking about it yet, but which one it is, but the state is sort of first in the fire. And then they're on this call, so if they want to speak up, I'll invite them to do that. But they've asked for right now for me to sort of keep it vague. The state is first in to do this, but the idea is to enable it to be replicated rapidly.
Sure.
When it comes to a lot of the HIE type things, as you know, we've had states that sort of sliced it their own way. So
Sure.
The goal is just to realize that people may move, and if we build that capability in early, then we can accommodate, I think, a lot of what you're talking about. So it's not national in scope yet, but if it were to be, that we wouldn't have to build an entirely separate parallel thing. Yeah. Sorry, carry on. I didn't mean to interrupt.
No, but so I think that comes to a point is figuring out a set of common data elements for common data model that can be broadly supportive of a range of use cases. And if the state is the one that I'm not going to say, but I'm guessing, it is one that has a reasonable diversity of urban areas and more rural areas, and large academic pediatric medical center on one side of the state. I think that you can develop that a model that can, if you can develop a model that can support that diversity in the state that I think you're talking about, then you stand a reasonable chance of being able to replicate it across a number of other states. And then to your second point about how does this bump up against, well, our protocol is X and we have new information. I think that's the beauty of a model that separates out the underlying data and the way that it is presented and implemented for local context, right? Because the correct answer to that is the underlying data represents whether the child has autism or a neurosensory processing disorder or however this data gets in there. Local instances have decided that is information that is relevant to their practice, and they will bring that to the fore for their pre-hospital providers. And so ultimately you actually integrate this into protocols.
So let me interrupt you real quick, and then we can come back to you, but I want to make sure I get to Ted as well. So thank you, by the way. You've given, you and I are going to be following up separately, right? So there's going to be a lot more to discuss on this. But I think what you just got there is ultimately we're going to want to go a little bit with this, and not necessarily on this call, but to give you guys a sense of where this is going, right? There's a lot here. This is not something for showing per se on screen. There's just a lot of detail. But what you mentioned is things like autism or other sensory processing disorder, right? How detailed do we need to go, right? And I think that's in other words, there is an ICD-10 code, right? There is a, we looked recently for COVID at the hematological blood disorder aspect for the CDC registration form, right? And when we looked at the ICD-10 code for hematological issues, there's like 6 categories and each of those has 8 items in it, right? So to the degree, this is where ultimately we want to go. And if we don't get to it today, that's okay. We're going to dig further into this in another setting. But if you are in the field, is it enough for you to know that this patient has autism, even though it may not actually be autism per se? It's some flavor of autism. It's not the top level category, right? Or do you want to get into a detailed level, kind of like John was mentioning, i.e. this patient has a chromosomal abnormality, you don't necessarily know what it is. And so there's a thin line there about what can go into an HIE, right? This becomes very practical from a technology perspective because we need to ultimately map onto data values for each of these categories in order to ensure that they can move around. So there is an approach that can be taken, which would be free text, right? That free text has gone the way of the dodo in healthcare IT, thank God. So, now we're talking about how deeply into the ICD-10 HL7 type structures we need to go and then map those backwards, as it were, onto NEMSIS, so the National EMS Information System, which is one, again, Clay, I'm probably going to call on you at some point, so be ready. But the idea that there's a top level, there is the equivalent of generalized pain versus tell me what's actually happening. And I think that's the thin line that we are trying to find where it sits. And sort of what I'm hearing from you, Bimal, is that it's a bit of a moving line. Some places may be prepared to deal with a very deeply engaged granular response, and other places may simply want to know, tell me that this patient is autistic so I know in general how to engage. Does that sound like a fair dichotomy that you're suggesting?
It is, although I suspect that if you actually go and ask people, do a little bit of qualitative work, there is a very steep drop off. There's a lot of information that you get from the most granular piece of information, and the marginal gains from getting more granular drop off really fast, is my guess, in the pre-hospital setting.
That is something that I think we're going to want to talk about. Britt, I see that you're not here right now, but I'm glad when you'll come back, we'll talk about that. Thank you for that. We'll come back to it. Ted, you're next. And then I think there's going to be people who may want to react very much to that question. And Zeke, being that you're a lawyer, I'm calling on you too, because the question of how detailed is too detailed, I think is something that you can probably weigh in on rather richly. Ted, you still there?
Sure. Thanks, John. I'm an emergency medicine physician in Orange County, California, and deeply involved in the pre-hospital system here in my county. And I was just trying to come up with other data that might, to an answer to this question you have on the screen. And to me, it was really about the purpose of why you're collecting it. And it really sounds clinical for the care that the pre-hospital providers are using. But I would hope that we don't lose an opportunity here to also use the data for purposes such as injury prevention, especially if you're going to do a statewide registry. I know in my own county, for example, that the drowning data is primarily that's published, or at least shown to everybody in the county, is primarily from the pre-hospital setting, and there's quite a bit of work around that to improve the data quality, and so that we can potentially, act upon any sort of trends in our community. So I just wanted to bring that up.
Yeah, I think so. So my understanding from the organizers on this is that the research, to the degree that there is at this point conceived, is aggregate. And that was the main point. I think that actually jives pretty nicely with what you just described there, epidemiologically, or from a practice perspective. And I think, again, if Clay is still here, Eric Cheney, if Clay, I don't see Clay's name on here right now, so I don't know if he's still here, but if not, Eric, maybe I'll call on you. Oh, there it is. I see him now. Clay, maybe I'm going to bump you in front of John Ferris. Sorry, John. We'll come back to you. But Clay, can you speak a little bit to how you would envision, especially if we take a national view, the alignment of local, state, national data against a broader registry data set like NMSIS, and sort of how you think we could ultimately use one to inform the other? Again, kind of with in the back of our minds, the question of how much is too much. And as we want to be able to communicate across the value chain from a healthcare data perspective, how does that fit with what you guys are looking at as you evolve NMSIS? And Faris, you're on deck.
Yeah, Jonathan, no, this is a great question and great conversation. This has been incredibly helpful for me. The NMSIS tech, since the beginning of NMSIS, we've kind of taken the approach that we would kind of try to develop a wide palette, right, that captures anything that may be important for patient care in the pre-hospital setting, and then allows states to choose a required or recommended state collection of elements that every EMS agency needs to collect based on the rules and regulations in a state, and then a core set that comes up to the national level. That way, it's allowed for some of this kind of flexibility to happen. What's happened though, right, is as we develop that standard, more voices become important, more EMS continues to expand what they do and how they do it, right? There has been some calls to place bounds, even on the palette, right? So do we need to develop a specific module for community paramedicine, a specific module for air medical, or even for pediatrics or some of these categories, right? Would there be modules that some states may want to implement and others not, right? But not have the palette available everywhere. So I think the model is a little bit dynamic. And so I think that this is incredibly valuable in coming up with these elements. What's too much and what's not too much is a valid question on several levels. Not only technology, but on the bandwidth of our providers. I mean, it just goes on, right, as to how you would define that. So
what's, let me just to push on that a little bit. So the process, obviously, the reason for bringing everybody together here is to try to facilitate some of that discovery, I think. But I think the point's been made, and Babel, I think maybe when he talks about local, is really kind of the one that gets my brain burning on this, is how do we determine how much is too much when it varies, right? So from a person who needs to manage that process and is looking at, by definition, the sharing of data, what insights do you have or have you received from other standard-based organizations that you work with, et cetera, other regulatory organizations that have basically said, if you do X, then you have to do Y. So you sort of run the risk of basically overloading just because you have to, or if you do X, then you need to make sure it's translatable into something else. And so again, you sort of end up with these natural constraints based on just the way data are formulated. And I think this becomes very clinically practical when you sort of say, if this, then that. How much knowledge is too much? By the way, we're going to have Zeke. I'm going to call on Zeke to talk about this from a legal perspective too. But again, how much is too much? And sort of how do you work with others in your ecosystem of data standards to determine what they need, and then sort of take that information back up? Because I think on the one hand, we could really use that insight at the early days, but it's also going to change, right? All those standards rotate around one another. So how would you see as the best practice to sort of figure out where the goalposts are, where the boundaries should be dynamically.
Yeah, I'm going to be quick here. And I'm going to try to stay positive and stay creative, because I'm loving what's happening here. But of course, Jonathan, when you start talking about the exchange of data, it becomes a nightmare, right? And even now, trying to move towards the 21st Century Cures Act, the final rule, and when you look at specifications for FHIR, which is the data exchange model coming about, there are complete attributes of pre-hospital care that are not represented in those specifications, right? So ONC is calling for new data elements, and they all circle the wagons around inpatient medical care, right? And so we're even fighting the battle of, hey, you need to understand that EMS provides impressions of the patient's conditions, not diagnoses. So we need to have codes other than ICD-10 CM codes that are just so hard to work with in the pre-hospital setting. So those kind of concentrating on ensuring that interoperability allows the same characterization of a patient's condition in the pre-hospital setting, that translates into the same in the middle and the hospital setting is difficult. So Jonathan, I think the linkage piece is a whole nother kind of conversation. You're right. We need to be careful about what's available and what needs to be added. Maybe that would be an important dynamic to keep track of in regards to the data elements and what's too much, right? I mean, I think that's probably less of a technology question and more of a who's willing to accept what data and to what level of complexity.
Well, you're a pediatrician, right?
No. I'm a PhD. I'm a PhD.
What I should say is NEMSIS sits in the Department of Pediatrics, if I'm not mistaken.
Yes.
So have you had related conversations on this? It is more just for history, and we can talk about this separately, but I wonder to what degree this type of conversation has come up with your colleagues at the university to basically say, as pediatricians, I mean, this is pretty much what we're talking about here, right? These are all kids. So I figured there might be some special interest there on a daily basis, and I wonder how that may have come up in any of your exchanges historically as you combine just by your environment. Pediatrics and EMS.
Oh yeah, this happens all the time, right? When we open up the NEMSIS standard for review, pediatric topics rise to the occasion all the time. And a good example is with NEMSIS 3.5 that just came out. There was a grand call for, hey, on a national level, you need to collect patient weight, right? We don't at the national level have that available for researchers to be able to look at diagnosing for kids, right? We don't have weight. And so it went back and forth. It goes through all the consensus building, and it did not end up being moved up to a national level in version 3.5. Very discouraging, right? I mean, that's an incredibly valuable data element for the evaluation of care for kids, right? So it's just kind of, keeping track of the circled wagons and making sure that what's absolutely necessary moves in the right direction.
Well, I appreciate that. As we go forward, I think you and I will probably geek out on this a lot, largely because, again, to Bimal's point about local versus national, we are trying to make sure that as we structure this for local use, we are not cornering ourselves such that it wouldn't be immediately applicable across the country. I think that jives very much, obviously, with some of the consensus building phrase. You mentioned that's, of course, the purpose here, too. So thank you for that, Clay. All right, I've got on order of discussion here. I've got Ferris, Zeke, and Dawn, who I'm calling on. Then Greg Babel, you're back. So if we can have you go up after Dawn, I think, given time, we may end up at bottom of the hour there. And anyone else, please do let me know if you'd like to be on order discussion here. So Ferris, you're up.
Hi, thanks. Can you hear me okay?
We hear you.
Excellent. So I think this is so valuable, and I appreciate your time and invitation to this. I'm a community paramedic by trade and by practice at this point, and I think it's important that we address what we're trying to do here more than just the question itself. We are actually trying to be proactive instead of reactive. That's very, very important in these patients. What I found from my practice and from an organizational level is that the biggest gap in care is the patients and the families having to manage their own stuff and provide us with an accurate history. Now, granted, in my career, yes, I have always advocated talking to the parents because they are sometimes the best historians. However, many times I have failed in the care of those patients because sometimes they didn't know some of the idiosyncrasies of what's going on with those patients. And in regards to pediatrics alone, sometimes harm can come from, just listening to family or patients. I think we need to have access to any and every piece of data that we can possibly get our hands on. And by that, I mean, when I go into the hospital as a patient, a physician, an EMT, it doesn't matter the caregiver, they all have access to the entire medical record. Having access to it and specifically accessing it are two different things. Your agency specific, like we talked before, ventilator versus non-ventilator EMS transport stuff, that, having access to everything is the biggest key.
So let me pause you real quick, John, because I think given you've worked in a lot of different contexts, Texas, Colorado, et cetera, other places, right? Speak to me. You just obviously touched on the point that we've addressed from the hospital informaticist side, and I think John Lovett in Massachusetts touched a little bit. And I'm certainly going to want to pick his brain on more on the granularity, but you basically said throw open the kimono. So again, if you're at the patient side, when you talk about wanting access to everything, are you thinking in a community paramedicine context where you've got more time? Would you say the same thing if you were rolling hot? So how does that question of sifting through things? John had mentioned, he actually has there's a comment in the chat here about a data screen with different categories so that you can decide as a clinician how deeply you want to go. I think that's a really, really interesting point. If you are looking at this data practically in the field, probably quite quickly, or perhaps you have more length of time to dig in, how does that change your position, if at all?
So my position on that is one in which we did with Epic while I was down in the DFW Metroplex. And we were able to get the most and DNR orders as a separate tab all in itself in one organization, in which if this patient was emergent and or crashing, the physician, provider, whatnot, could look at that tab immediately and without having to sift through and sort through data. I think we need to look at things that need to be treated emergently and be able to sift through that data quickly, patient-specific protocols and or advanced directives and or whatnot. That should be like a separate tab we could access very quickly and emergently. Then on the flip side, from a community paramedicine standpoint, if I want to look at someone's A1C, or if I want to go crazy geek out and look at the light chains that were pulled on a patient for a multiple myeloma case, I should be able to have that access. And this primarily comes from a couple of anecdotal results in which I had pediatric patients that were having significant blood sugar issues, and which I needed to know their A1C and what it was trending, what it was doing to work with the patient's endocrinology and primary care and things of that nature. I also was able to take a medical student that I was teaching and actually find a patient who was misdiagnosed, and quite frankly, it was lost that she had a diagnosis of multiple myeloma, and I had to get that patient in immediately.
Let me push a little further. So we're talking the category that I sort of heard you speaking to is essentially data triage, right? So prioritize, right? So when you look at something like an A1C, is there ever a context, and now I'm kind of taking it to a technical design level, but is there ever a context where as a paramedic, as a firefighter, as an on-scene emergent provider, you would need to know historical trend data on someone's A1C, or is that always going to be a longitudinal question?
I would answer this from two contexts. From most physicians and most ER physicians would say no. However, from a community paramedicine standpoint, and from a community paramedicine standpoint, I would say absolutely this is going to be key. So many patients that we roll up on, and probably the most litigious EMS call is that of one of a hypoglycemic that we revive with D50. And if the patient's A1C has been trending appropriately or higher or lower, or it's going to make my decision's a little bit different. Now, most medical directors will advocate for transport of these patients, but as we all know, they don't get transport. And many times these patients are left at home. If this patient's had a very, very stable A1C, forgot to eat whenever they took their insulin, then I can do telehealth with a physician if the agency has the ability, and we can discuss that. The problem is whenever these patients have all over the place blood sugars, and they are what's called brittle, highly inappropriate medical term, but they're self-diagnose themselves as brittle diabetics, and then we leave them at home. This can be a big deal, and I don't want to get too much into the weeds on that, but documenting patients and or knowing what the A1C is, knowing what the average trends are recently, is very, very vital information, even on the 911 call, I believe. I'll let the physicians weigh in on that a little bit more, but I think it's very critical to the patient's care.
Okay, perfect. I appreciate that. I also punted that question to Greg. So Greg, you're gonna be asked to give perspective from both sides of the line there, or the other side of the line on that. We'll come back to that. Zeke, I saw you came off mute. You have just you can give your own background, but I think you bring some interesting and important perspective here, covering really 3 overlapping aspects of relevance. I will just say HIE field clinician, right? So you represent.
I don't know which. Can you hear me? I don't know which device I'm on anymore. I was in the car and now I'm back at the computer.
We hear you loud and clear. I was just saying you are an attorney, you are a medic, have been an agency leader, and you are also at an HIE. So I think there is an enormous amount of perspective that comes from your view on questions like how much is too much on a variety of dimensions. So if you can dig into that a little bit, I think we are really.
So if I say I've had enough, I can just go then? Is that what that meant? No, I mean, I feel like my understanding was that, you know, you're asking for framing here. I got into this about 25 minutes in the call, so I don't know if it's brought up already or not, but I'm gonna just take a little different tack and hopefully it'll arrive at kind of where I stand kind of relative to the things I've heard. And that is that, you know, it's really clear as maybe the only anointed EMS director in HIE who actually has more of a population disaster focus as it works out, as personally, that, you know, our strength is not ever in being the first or final mile, right? We're talking about that. And so the places that for me in sort of thinking about what's in the data repository versus what's surfaced, what's made available, how it's made available, are really questions about, you know, which stakeholders should drive that and how they should drive that. And so the only way that we have moved in the final mile business is because there's been some compelling piece where it hasn't been done, right? And so in this case, it would be like, what's the delivery of these special data related to these special patients? And, you know, we haven't gotten there yet. We started that conversation in Colorado, which I'll come back to. And obviously with COVID, we, you know, we've done a bunch of work that would not traditionally be in our orbit because there was sort of nobody else to do the analytics, to assemble the data and whatever. So, but by and large, that's not our strong suit. And so to this point, you know, and I'll let Dawn speak to this more because, you know, she was at Carrillo when this started, but we were approached by EMSC here to see if there was a way that we could deliver the AAP-ASEP emergency information form for pediatrics. And what stood out to it about me was we were doing advanced directive work at the same time. And we're not going to do this way now for reasons I'm not going to get into, and you know, it's a limiting factor. But at the time, we were going to use a platform that was more like delivering the most form to patients, providers, patients, physicians, and then on into the field that looked more like it was a user-facing tool, right? That was designed to sort of perform those functions as clinicians and humans would want them done, not as raw data, right? And so I think that when the ASAP AAP emergency information form for pediatrics came in front of us, it was like, oh, well, this is just another set of advanced directives, right? I mean, this is really the thing. And in fact, to the point that form, in my opinion, is so good, and I had never seen one in the field, that it says things to do and not to do and why, right? Which kind of gets to this point. But it's the nice part is it's a direction then from the physicians, you know, and the patients initiated in either place, right, or other kinds of providers, that has this form of advocacy that's actually potentially usable by me, particularly if it's thought through, if EMS has a stakeholding in the development of that. And so that's how we tried to do the engagement, which, like I said, we're not going to be successful in that effort to deliver that. But I still think it's fundamentally the right approach, because it has some key stakeholder user groups and use cases that are at the fore then as a result, right? If you start from that point. And so, you know, when the conversation was going on in our shop, it was like, well, of course, we would want structured data elements that are as standardized as possible to actually feed this form. We wouldn't want to have it be narrative and completely qualitative and whatever. And that we should have those, if we can't use existing elements to feed those on an existing standard, we should figure out how we would get the elements in and exchange them, right? And also that the possibility exists, what I hear here, which is that essentially that you might be able to double click and get more information, right? So if the diagnostic field feeds something, you could go further into assuming you're appropriately privileged and whatever, which also gives us a lot of options to your question about what's the right amount of info for whom. Well, you know, that's a thing that can be decided locally or can be decided within, say, in our context, within the HIE permission structure and whatever, right? Certain people are essentially qualified because they're a, you know, known EMS provider that's viewing this somehow in an ePCR tab that has, you know, exchanged this information to see the form, but not really to get any more info. The second piece of this is that, you know, I've worked in every kind of system. I mean, I started in rural Alaska, and I'm essentially an unreformed Denver paramedic, and I've got the spectrum across, you know, across the board here. And I will say this is that you know, what I don't need any more of is having somebody deliver me a document or verbally tell me some obscure diagnosis for some child with one of these chromosomal abnormalities, and then I have to read the Merck manual to try to figure out what the hell I should or shouldn't do, right? I mean, it's absolutely useless. And so if that isn't the use case that's deriving, you know, and like some very practical things about, I mean, I'm not even going to get to the ventilator component, like practical shit about how to do venous access, why, when, you know, and to sort of make risk-benefit assessments in crappy situations, resuscitation situations, is like, that's what I actually really like as a provider. And so, you know, I just think that we absolutely have to watch this phenomenon that goes on all the time in this business where, you know, the data should be the tail on the dog here, and the dog sits somewhere else with a bunch of patient needs and whatever else. And we have this, you know, problem about what to do in the wagon all the time. And so I think that, you know, starting with something that we could rally around, like, let's say, okay, well, the conceptual frame under which, you know, I would say this ASAP AAP form is built around in terms of how it engages people, then is the one. And frankly, all these kinds of issues about consent and access and whatever, if the people, you know, that's a bunch of people who are filling that out, or, you know, filling out whatever the fancy digital version of it that's interlaced, who are stakeholders, right? And so they're the ones to have the debate about, you know, how far the double click takes you, whether the form should exist at all, whether you want to fill it out at all or not, right? And then there are other kinds of problems that could go with that, right? Do we have sufficient outreach in the pediatrician community and the EMS community to make sure these things get done? But that goes with a lot of what we've tried to deal with advanced directives, or trying to deal with advanced directives right now. So anyway, I mean, you know, that's Zeke's view of the universe. As usual, you were dumb to ask, but, you know, now you got it with both barrels. So,
well, I think the one thing that I would ask you to add onto that, and then I'll call on Don and then go to Greg. I think we're going to take it to the bottom of the hour. Is Zeke, when you put your lawyer hat on, right? And again, there are lots of aspects you just mentioned there that go to the question of how much is too much, and I love the idea of double click to expand if your permissions allow. Yes, Greg, happy to have you go next. Sorry about that. Don, you're getting bumped. Apparently he's got a time constraint bottom of the hour. Sorry. So Zeke, again, like legally speaking, and maybe we'll come back. Let's put a pin on that, because I think we probably in the interest of time, but I want to pick your brain on, if you were going to advise legally as counsel an agency on what to do, what they can do, what they shouldn't do, what's just too much, how much is enough, etc. I think we want to unpack that. Yeah, let's put a pin in that, but I'm sure I get it on record here so that we can come back to that, because I think that's a very important alignment we need to do between both sides of the handoff, and make sure we keep the informatic structures in mind as we do it to make sure everyone's covered. Okay, Greg and Dawn, looks like you're both competing for short time scales here. Can you each be, can we get both of you in the next 9 minutes?
Not a problem.
All right. Sorry, I don't want to lock anybody up, and I also don't want to cut anybody off. This stuff is so good.
So I'll go Micro Machines talking speed. So just for you guys, my name is Greg Babel. I'm a pediatrician. I work with the South Carolina Office of Rural Health to trying to coordinate, as a former chief medical officer for a Medicaid managed care organization, trying to coordinate the work of community paramedics into the value structure that the insurers have, so that the value that they're receiving in terms of the the savings is reflected and can support the community. I think to Ezekiel's point, and I kind of really, to me, I mean, if we need to start one place, and this is just from historically, and Stephanie may know, being from South Carolina, some about this, having a DNR that can follow, and so that the patient's wishes are respected, because that is one of the most heartbreaking things I've ever seen. In the hospitals, these kids that come in where they were ventilated, or they were intubated, but that was not what the what the wants of the family was. And I think after that, I mean, really just the concept of an advance directive, a patient, the doctor being able to advancedly direct an EMS of, and I break it down to, is it F'd or not F'd? The information you need to know, of like when you see a patient, of knowing, what's a horse and what's a zebra, that those are the components, to me, is the start and the structure, because even to me, there's like, and that kind of information is still, it's relevant as much as when EMS is going out to a patient's home, to when we sometimes get kids from outside hospital, and and the management is against what the standards are. So I think overall it really does come down to the what do I need to know right now to keep to either keep this kid alive, or that this is not someone that wants that type of that advanced type of care.
So thank you for that. And so I just real quick, and thank you, by the way. You and I know you and I can go on for hours about this, and we will. But the end of life orders, whatever form they take, whether they are DNR or a PULST or MOST or most, whatever they're called in each different place, COLST in some places, that is an endemic part of this. It's actually one of the things that got us interested in it, and very, talk about ripping your heart out and stepping on it before you stab it. The idea that it's a kid who has an end of life order. But as you say, it's a reality. So it sounds like what I'm hearing from you is that your primary focus is sort of at the, do I do anything before anything else question. So you're really taking this in a hierarchical perspective, I think.
Right. And what I'd love to, and I think, the interaction with the American Academy of Pediatrics, but, the pediatric councils in each of your states, if this is something that's pediatrics and that you're interested in, I want to connect you to your AAP chapters, so that they know you know them, and they're going to have a much different input than our national, committees are. At the same time, absolutely connecting to the Council of Clinical Information Technology. And for me, and for what I want to bring to this group, is always looking at the lens of, for the people who are benefiting, better care, save dollars on the insurers, how do we make them recognize it so that they support it? Because none of this work cannot continue to go unrecognized. For everything that you guys do, and everything you're doing for longitudinal care, which is really what pediatrics is about, it has to be recognized, and it has to be paid, not reimbursed. Not you do it and someone gives it's paid. So that's going to be my goal with working with you guys.
Thank you. Dawn, I'm going to call on you real quick, and then Gorosky, you're after Dawn. I know some people are going to have to drop the bottom of the hour. Greg, you and I are going to brain juice quite a bit on that topic. Thank you. And thank you for pulling this together and really helping us spread the word. Dawn, you're up.
All right. Yeah, I think a centralized, some type of centralized data repository is definitely needed for stuff like this. As to how it's dispersed, I think that's.
Well, let me direct a question to you then here, because you worked in Colorado on HIE, and now you're in Nebraska, right?
Yep.
So very, very practically speaking, going back to one of the points that I mentioned when we started, you have a patient who lives in Denver, they're in Korea, they move to Lincoln or Omaha.
Right.
Go, right? How do you do that now? How should it be done in an ideal world? Because the information's there and the child didn't know and the parent didn't realize that the stuff was in the HIE. How do you close that gap? And I think, Clay, if you're still here, this is certainly speaking to you too.
So patient-centered data home, it's an XCA, it's a technical web service call, goes to a centralized repository where HIEs can deposit data points on their patients, and it will direct, depending on the level of participation in the PCDH, the patient-centered data home. The HIE will either allow, yeah, we've seen patients here, or they'll pitch you back a comprehensive CCD of the patient from that particular state.
Are you, so Zeke had mentioned the training bit, or the teaching people how to do things. The concept of a patient-centered data home, who are you educating about that? Is that clinicians? Is that individuals in the state? How are you even telling people to put data in this place?
It's an HIE thing, and there's not, if you're an HIE and you want to participate in your regional PCDH, it's strongly encouraged. I'm not sure if it's regulated by CMS or ONC, but it is there. The regional repository for PCDH is actually in Utah for the western half of the United States. So that is where that's at. And again, it's the query is based on each HIE's participation.
So essentially what you're describing is basically a sort of centralized outreach model, where you're viewing a role for whoever the interface is between the HIE and the clinical community, is what I'm hearing.
Right.
I think that's certainly going to be relevant here, insofar as the discussion of how to train people to use this thing, right? And that's one of the big points of conversation, a little bit beyond where we are today. But I know you're going to be on other comp calls, and we know how to find each other, so I'm not concerned about that. But the question of who needs to be educated, who is the evangelist? How, if you are looking at the vast realm of sick, disabled, and injured children, for example, in any jurisdiction, you can be in Texas or you can be in Rhode Island, and it's still a beast. So figuring out what the right vectors are and how to train people to keep their information updated is, I think, one of the big topics that we're going to need to come back to, because we know that personal health records that individuals are required to update are a disaster. Just they don't work. That's why Google Health shut down and Microsoft Health shut down. So to the degree that there is an overlap here between some responsibilities that we impart onto the patient's family. Obviously, again, you're talking about kids, right? So on the patient's family to say, this kid was diagnosed with something. If your clinician doesn't participate in an HIE, how much of that do you have to take on yourself if you want to be the advocate for your child? If you do participate in the HIE, how do we get more clinicians participating in it? So I think you open up, and again, I apologize for sort of jumping in on that. I think it is an enormous topic in and of itself, how to educate different communities. So I'm glad it gets mentioned today. I think it's part of it. And I think it also touches on the question of how much is too much, as well as, again, if you are a patient who knows that your kid has hemophilia, but you don't necessarily know what kind, or they have muscular dystrophy, but you don't know the differences, right? How much information do we expect people to put in about themselves, and get it right and deal with quality issues that we've seen come to light in light of COVID more than anything right now? So, and HIE patient matching and all the other stuff. So thank you for that. I'm going to make sure that's incorporated in our discussions here. If you don't mind, in the interest of both your time and everybody's, let me jump to Goroski. Mike, that was, Bamal, thank you for being here. I'll make sure to follow up with you about some of this stuff. Goroski, you on?
Yeah, I am.
Perfect.
So the question I had that I could throw out there in regards to all of this, we're dealing specifically with a, the term frequent flyer, and it would sure be nice to know what the receiving facilities are doing with this patient, but we're not finding that out necessarily, or we're not getting good quality information. So if there's a QA, QI component to all of this, where we could have an open discussion with these care providers that could give us information and give us recommendations, and we can answer questions going back to them. It could come full circle so that this patient can receive the best quality care.
So I think that's a perfect place to close out this discussion. So let me push you a little bit on that. In terms of both what you do today, right, what your engagement is, given where you are, you have smaller communities, right? So you're up in the northern plain states. So I would imagine, and tell me if I'm crazy, but I would imagine you can have more interface with your communities of care just because there are fewer of you. On the one hand, talking about how that would translate to someplace like Los Angeles or even a mid-sized location, but hey, take Fargo or Minneapolis or Chester County, South Carolina. I see Britt's name here, right? So how that conversation you think would evolve if you just have more and more volume of participants, both on the patient side and your side. At the same time, what do you do today, right? So what kind of analytics, aside from the fact that I know technically what analytics you do, what kind of conversations do you have with the other parts of that ecosystem to have that case review or regional approaches to learning? What's it like today? What would you add to it? And I see that Zeke added some comment on that too, which is wonderful. So speak to the status quo and speak to where you'd like it to go in an ideal setting.
So right now we have a really good relationship with our critical access hospital in our local community, and then with our transports to our level 1 trauma center, which is 50 miles away, and another facility in that same community. We have a great relationship when it comes to stroke and STEMI, but outside of that, we don't get a lot of feedback, if any. And so I would like to see that get improved, because otherwise, doing a run review, I'm looking at what the crew said, but I can only see it from their perspective. I'm not getting feedback on what really came about in all of that. They can write a beautiful report, but it could be all wrong for all I know.
Okay. What do you, so let's assume you're talking about a child who may be a cancer kid. Are you liaising today? Would you like to liaise as far down as that patient's pediatric oncologist? So does the ecosystem exist today in your community, which again, rural, regional? Tell me about sort of what that looks like, where if you were to say, I transported you to the hospital, I know who to have a conversation with over there, but ultimately the feedback you're describing would come from somebody who may be in a doctor's office setting, completely separate from that transport. What are you looking for in terms of interoperability that way in its grandest sense?
Right. So somebody in my agency, and then the ER physician, the primary care physician, the therapist, the specialist, all of those people could be a part of a group that would add input.
How much of that happens now?
Very little, if any.
Okay. So what I'm hearing is I think touching on what Dawn had said, part of the education process is not just a technical education on how to use this thing, but basically on how it would be an enabler of exactly that type of better perspective, just in case when it hits the fan, everybody knows who else needs to be informed. Is that an accurate? And I think, Faris, that would touch on some of what's close to your heart in terms of justifying access to data, right? Because it's one thing, this is one of the big challenges as technologists we deal with, is there's a very delicate balance. I see Eric Cheney is on the call. I know that he deals with this at the federal level. And Eric, if you want to speak to it, obviously I'm happy to hear your perspectives all the time. There is a very delicate balance between access to information and protection of information. There's a difference between practice and law, right? So what we would like to give versus do the structures exist to give it? And I think a lot of the driving force, Mike, which you just hit on really eloquently, is you provide a context for why this matters. It's not the idea of, even as we talk about comp in these conversations, right? It's not just about getting paid. It's about what could you do if you had it? So not in other words, shifting the frame. So it's not focusing on the mobile medical provider or even the non-mobile medical provider. It's really focused back on the patient and saying, you've kind of got a cloud of information around you that is not accessible. If that's kind of what I'm hearing from you. And if we made that accessible, then we can make it rain, so to speak, in terms of it's not a cloud anymore, but it becomes very, very practical, and we can all sit down together with you in the right context and say, this is what we learned. And so this is what we're going to do the next time you, as a chronic patient, may have an encounter. Is that a fair summary?
Yes, exactly.
Wonderful. Zeke, this is Mike Gorosky from North Dakota. No, excuse me, from Minnesota.
Both.
You're on both. I would say I look at you as being on the board. So and Mike is a frequent attendant to CoMMP. If you wanted me to make the connection, Mike and Zeke, I think you guys would probably have.
I couldn't remember the last name, Jonathan. That's why I sent you that note. So
you got it. You got it. No, this is, like I said, Mike is, I think, incredibly thoughtful about these topics, and his context is very interesting and unique because he does cross state lines, and also some very different types of communities. And so I think the needs, I'm always glad that he's here, because there's a perspective on that rural care environment that often gets neglected and is hugely essential to these topics, right? I mean, we have to. Okay, so Eric, if you're still here, I actually would love to have you capstone our conversation today, if you don't mind, if I can sort of call on you a little bit. Are you still there? Can you hear me? Eric Cheney, going once, going twice. Okay. If that's the case, if he's not there, then I will, look, in the interest of time, I think you guys have all been unbelievable in your interest in exploring those. Zeke, by the way, it looks like there were some other aspects you added here about the role of HIE. That's what I want to make sure we touched on. So I'm still seeing your face here. If you want to add a little bit of detail on that, and then I think we'll close it out. You guys have given everybody an extraordinary amount to think about. We will be poring over these details and coming back to the CoMMP crew, as well as to the clinicians who've been around us, and you're always welcome to join us in CoMMP for these types of discussions. I hope you guys all feel that this was a great setting for this, because it really is multifaceted and multi-stakeholder. So Zeke, take us home.
Well, that seems like quite the charge. No, I think for people that don't know, right, that the main work that our HIE does, and I think in many other HIEs interface with EMS, is they sell the products that they sell to other clinicians, repackaged for EMS, not in a way that's useful for immediate field care. And so that's sort of, my emphasis, because the first part of what I said earlier. However, where we do really add value currently is by allowing people to get access to the longitudinal records so they can do this follow-up in QA programs and so on, or whatever format it is. And of course, this is, I don't think this actually changes any of my earlier comments. I mean, to me, this is yet another double-click expansion, right? You have the special patient population, or maybe you didn't know you had a special patient population, but as a result of, say, being delivered the digital version of the ACEP AAP form, you end up realizing you should click through, right? And you have this relationship already, right? Which would be another longitudinal connection that could be made. But we have agencies, quite a number of agencies in Colorado that have their QA officers or others who are similarly situated use the HIE to understand outcomes, ultimate diagnoses, whatever, however the learning loop works.
Do you have a section in your HIE for children? Is there a specific subset in there where that would be something sort of be a natural extension to connect with this model?
No, they're just patients. We deal with individuals, and so that's the challenge if you want to do population stuff. But if you're trying to do individual patient follow-up, right, essentially, then the two things that we could use for our patient follow-up and getting demographic information, which goes back to billing functions inside agencies, currently. But no, we just deal with, we have a lot of individual records. And
so I lied about you taking us home if John Lovett is still here. Lovett, are you still with us?
I am.
All right, I'm going to turn this to you, and then I really will have it take us home, unless you spark some other discussion, I guess. But you were very forward about the relationship of this to your particular life. And one of the things that you and I have talked about in a very compelling and emotional amount of depth is that your child grew up, right? So I think Zeke makes an interesting point about the idea of patients being patients in the system, as opposed to patients being kids and then they age out, right? So how would you, if you were going to put information into a repository, an HIE, electronic health record, an EPCR, whatever data system it is, how would you want to represent the fact that today they're a child and tomorrow they might not be? In terms of, again, that critical information, not the fact that they have a cold, right? But the stuff that's not going to change. The fact that they have something about their person that you may want to watch, and you may see this person, you may have last seen them 10 years ago, but some of these things are still there. What's the practical approach you would want to see taken as a parent, as a clinician that works in a hospital-based EMS system? So you kind of got a lot of aspects too.
Ooh, where do you go with that? All right, so
where you want.
Yeah. So yeah, you're right. My daughter has quote unquote aged out of the pediatric population, but she is still a child from a cognitive perspective. So that doesn't change for us. And I would like to see a program that you can utilize and, if you will, manipulate in such a way that no matter what, your child can stay within it. Because at the end of the day, they're always going to be our children. They're always with us. They're always in our care. So regardless if my daughter is 1 or like now when she's 22 years old, I still refer to her as my child because cognitively she won't proceed past that, but her healthcare needs will remain the same. Like from the cardiac and neuro perspective, she will always be a Boston Children's Hospital cardiac patient and a repository that we could periodically update to include the most significant data as a parent would be significant to us, because obviously her medical history now is much different than when she was born. And, you know, when she was born, she had the initial diagnosis, and now that she's had 36 surgeries at Boston Children's Hospital, there is some of that information that I would like for EMS and first responders that would have access to, that would be pertinent to them. Like, you know, they don't need to know about her canaloplasties, but they're certainly going to want to know about her ASD, VSD repair, her diffusely narrow left pulmonary artery causing pulmonary hypertension, and the meds that go with that. So from, you know, I look at, like you said, I look at it from both a personal perspective and a professional perspective, in that growing up with a child with healthcare needs where we didn't have any of this, and growing up in a small rural community where if I did call the fire department and being a paramedic at the time, they would divert to me and, you know, ask me to be the lead caregiver as well as the parent because of my experience and my exposure. So, you know, I would like to see a program that can encompass them from life to the end, whatever that may be, depending upon the, you know, that person's disposition.
So it sounds like, in addition to talking more about the clinicals that you and I will do separately, one very stark takeaway is that while we know that demographics are a part of this conversation, age as a dividing line would be inappropriate.
Yeah.
And that's something we need to keep in mind, to say that you may be a 40-year-old child and not just what my wife calls me, right?
Right.
So that's a very important consideration. That's a critical takeaway. I'll make sure that we incorporate that. I mean, there may be somebody, I think it goes to what Clay had talked about before as far as weight in children. If you are in a pediatric registry classified as a child based on some parameters, but you need to be given medications with the dosage of your biological age, right? So that's a very important dimension. Okay, thank you for that.
Jonathan?
Yes.
Jonathan, can I make a registry comment based on that exchange? I want to, so right now I'm in this weird dual-hatted role where I'm sort of attorneying at Carrillo as well. And so as a result, I'm deep into the prescription drug management program registry and the immunization registry around it's COVID uses on the immunization registry, and to some extent on the other registry, but also the narcotic epidemic, right? And so these registries weren't built with those purposes in mind. Again, we're back to no use cases, right? And so I think they kind of suck, is what it comes down to. And I say that in a policy sense, a legal sense, a structural sense. They're not very nimble. And so the problem with calling things registries is it's like once they're registered, it's like the data went there to die. It's like birth certificates and death certificates. Yeah. And what I think that the reason I say the model, what I hear from John and what I've heard elsewhere is, look, if we had looked at these simply as forms of things that people wish us to know, right, and ways they wish us to act and so on, and that was the beginning point, then it makes perfect sense that maybe, John changes from the AAP form to a streamlined power of attorney, or that they're both in there, because that he, basically the best thing we could do right now would be give him a phone call, right? And that's the kind of crap that the current data structures and then the regulatory structures around them, they don't account for that at all. And so I really feel like we have to build out from the kind of stuff that John is talking about. And to me, the place I've seen that occur the most to date is in the stuff we call advanced directives.
Well, I think that's the perfect capstone point. Guys, thank you everybody for giving us so much to think about, for obviously taking your time on this. This is not going to be a short conversation, but from a technical perspective, you guys have given us a lot of direction, I think, here, how to incorporate, for example, Zeke, just what you were talking about there. Why do you have to have only one form when maybe you need to have more than one? And the ability to allow people to dig through to more or less detail based on the circumstance. So couldn't thank you guys more. John, you just came off of mute. Did you want to add something? Oh, okay. So no, you guys have been wonderful. I think there's so much here, and I think Zeke, if I may give a plug and a pat on the back to CoMMP for this and the team that brought me to this project. I think they're trying to do exactly what you just described was not done before, which is to bring this to the crews, right? To ask you guys what you'd actually need, as opposed to doing it as just a technical place for data to die. We want to make sure it is useful, and the only way to really do that I know of is to ask the questions. And basically say, what would each of you need personally, professionally, in your different contexts? So you guys have given us an enormous amount today. The folks who are running this program at their states are on the call hearing this, so they have heard from you. And again, in the mission of CoMMP to combine, the silos. And Ferris, I see you raised your hand. You want to add something there? I'll let you end it.
I guess my end point would be, if we do anything, let's do something. As we talked about all these different things that we could add, couldn't add, yada, yada, yada. The first thing is advanced directives that we've been trying to get at for years, and you could almost say decades. If we do something, let's just do something forward momentum-wise. And we've been stuck in this litigious or permission-based loophole for years. And I think if we do something, it's better than what we've been doing. And if we do something, at least we'll have something to show for it. And that's my only ask.
I knew there was a reason I like you. All right, everybody, thank you guys so very much. I'm going to look at you guys back to what it's the lawyer's fault. All right, I'm going to put you and Zeke together. You guys can have your fisticuffs on that. No, look, I think this is a step toward action, John, just considering the amount of time that you guys have put in today. But there's a lot of people with a lot of passion who are doing this, and we are not known for being subtle or shy. None of us, I think, on this conversation we are people who are going to look to have deliverables. And so what I'm working with my team and with the organizers of this project on is really to, I don't want to say bite size, because I don't think that's the right word. It's really, John, to your point of momentum begets momentum, right? So instead of trying to eat the world, we are going to show that something is possible. And as such, build the momentum to get people to say, what if you could do this? And I see Gorosky's name in front of me. I see Britt's name in front of me. I mean, you guys, again, in your respective communities have been working to do this. In that community, bridge those gaps. And so we are doing this together now. And as a technology team, I think it's a remarkable thing to be able to break this up into phases and stages and be able to say, look at what I built, look at what we can do. And I mean that, from each of your communities, so that it gets people saying, we didn't know we could do that. And now that we do, what else could we do? And so Ferris, I think that's the inspiration I try to take from folks like you and from everyone on this call, that we are going to turn this into practical steps. The deliverable, by the way, on the first phase of this is the end of September. So this is not hypothetical, it's not theoretical, and it's not far away. But between now and the end of September, this will come to fruition. And then the question will be, and maybe we regroup in October. Obviously, we'll regroup before that, but we come back and say, based on phase 1, what does phase 2 need to be? And that's where we're going to take this. So, any last comments? Otherwise, I'm going to thank you guys all again for giving up your morning or afternoon, depending on where you are. Tony, if you're still here, it is Funky Friday or whatever drinking time is that you do in the afternoon. Glad you made it. Ultimately, Tony Correa brought all this together, so a round of applause always for him. Anyone else want to add anything? Going once. Going twice. Thank you guys all so much. Stay safe. Have a great day.
Bye, Jonathan.
Take care, y'all. Bye-bye.